All right, it's another Thursday on the ticket. We have 13 studies to get through, so I'm basically just going to read the title, the results, and we're going to rapid fire all of these. If there's a point where I want to give my thoughts, I'll give them then, but there's a lot on the docket tonight. So first one, excessive cholesterol accelerates intervertebral disc degeneration by promoting the polarization of M1 macrophages. So this one basically wanted to take a look to see if cholesterol had a potential causal, whether directly causal or indirectly causal uh, relationship to people developing intervertebral disc degeneration. Basically, they found that it was at least a risk factor. So on the conclusion, results reveal excessive cholesterol is a risk factor for intervertebral disc degeneration, emphasizing its direct role in the process as well as its involvement in signal regulation during that macrophage polarization. So they like to say, therefore, cholesterol lowering therapy may provide new opportunities for the treatment of that disc degeneration. Now, really, it's one of those things where whether or not it is causal, whether or not it is a direct risk factor tied with active degeneration, this study likes to make that leap and at least show it has the propensity or possibility to. Frankly, if we just have excess cholesterol, this is one of many things that is on the ticket for your body adapting around and not adapting around in a good way. Now, we could go into the nuanced debate about cholesterol levels, how they've been dropping precipitously over the years insofar as labs and what the new standard are when we come to lab ranges. So, there was a time when we could have 250 on our labs and it'd be considered quote unquote normal. And each lab is slightly different. So really, we're having a discussion on where is the cutoff, what is absolutely high, what is functionally high, what is, what parameters do we have for the people with like a familial hypercholesteremia and different familial genetic diseases. There's a lot more nuanced discussion to the debate of what is truly high. Suffice it to say, high cholesterol for you with a nuanced discussion with your healthcare practitioner where it is legitimately high, where there is concern because your total cholesterol is off and you have a poor ratio between HDL, LDL, and all the other cholesterols, you will likely develop or be at a higher risk to develop things like cardiovascular disease. Now we're throwing in intervertebral disc degeneration. There's a lot of things that can go wrong if we don't take care of our health. To me, this isn't one of those things where I'm going to jump and just say, oh, yeah, you should lower your cholesterol because you're going to get disc degeneration. No, this is something that I'm now including in a plethora of things, of reasons that we are going to discuss getting a better overall picture of health. That's also why I do open access lab testing. So if you haven't had, labs like a CBC taken in a while, or a lipid panel, or things that actually can assess your health that we should be doing more than just once a year, this is why we do it, because we need to take a full picture at your health, whether we're discussing pain, performance, no matter what we're discussing, we need a clear picture on your health. So to me, this is just a drop in the bucket for another reason why we will test labs on the people that need it, and why we'll have discussions about meeting appropriate ranges for the individual in front of us. So interesting study. Next one. Altered proprioceptive weighting and trunk muscle activation in individuals with recurrent low back pain, a cross-sectional study. Long story short, if you're in pain, you'll develop an altered movement and moment and motor pattern when you're doing certain lifts. So really, this is just here to discuss, when you're actively in pain, and you feel weak doing a lift, you don't necessarily have to skip it. Are you moving the same way you did before pain? Not likely. Is that a bad thing? No. It's just a factor that we work with and gives us a reason to modify what you're currently doing. So more than anything else, this just really gives you a reason or a purpose to think, why do I, look, I'm in pain, but I can push through pain. Why can I not lift the same way? Why can't I push the same amount of weight? I'm just getting angry. I'm just getting flustered. It's because your body's just seeing what resources it has available and executing the most simple and effective strategy to do that movement. Now it's factoring in pain. It's presuming that you have less resources at hand. And if a lot of lifts, as far as maximal weight during free weights or maximal weight during a lift that is actually technical, breaking down technique means you're actually not going to be able to lift as much for that lift. Does it mean you are going to atrophy and that you are legitimately weaker before you had this acute bout of pain? No, not at all. Your technique is just temporarily not the same because you're in pain, and that's not a bad thing. We work with it, we work around it, and then we get you back doing what you were doing before to the best of our ability, if that's what's required. Or depending on the nature of your illness or injury, if it's something more permanent that's going to alter your technique pattern more permanently, like a post-operative case, then we just figure out what is the most efficient movement strategy for what you want to do after that fact. So again, kind of like the other one, I'm not too worried about it, other than it gives us a reason or an education bit to talk about and get through some of the frustrating aspects of people in pain and why their gym sessions or sports sessions, in their mind, it may be one of those, they suffer like, oh, I can't do X, Y, and Z. It's like, yeah, okay, so let's just now build a different new strategy that works for what you got right now. It's not doom and gloom. It's nothing to be too concerned about. You know, it's just something to understand. Is there anything else I want about this one? Anything else that I said that is or is not in the conclusion? Oh, they basically try and allude it to the pain will dampen your ability to sense where your back is in space, and that is the reason why you adapt the new lifting strategy. Yeah, and one of those things where it's like, yeah, okay, cool. So what? Like it's just a talking piece, just an education talking piece for the people that need it at the time, and not everybody does. But like I said, we've got 13 studies. Let's just keep going. Sleep apnea syndrome mediates the BMI chronic pain link. So what does that mean? Well, I think it was last week or the week before, we talked about how obesity was a risk factor, and a high risk factor for developing and maintaining chronic low back pain through direct and indirect reasons. This is one of those things where it is through the mediation of sleep apnea. So higher BMI obese individuals are more likely to develop sleep apnea, typically like a partial obstructive sleep apnea, where tongue, tissues, etc., will block the airway and they will not be able to get as restful of a sleep. And through that reduction in sleep quality, they're going to exacerbate their whatever conditions they're suffering from, which will include or can include chronic low back pain. So conclusion, there is a causal relationship between BMI and chronic pain, with sleep apnea acting as a mediator for at least a portion of the causal effects of BMI on conditions such as limb pain, low back pain with or without sciatica. Clinical strategies focus on modulating BMI levels to maintain them within normal range, which could effectively reduce the incidence risk of that chronic pain. Furthermore, in patients with elevated BMI and comorbid sleep apnea, targeted sleep apnea treatment could potentially mitigate BMI-associated chronic pain burden. So different discussions for different interventions, the most common one being a CPAP device, that continuous positive airway pressure device. They've gotten really, really great. They're not as intrusive, and there's lots of outfits, even one on Main Street, that will actually personally fit one to you, because a lot of the time, if it didn't work for you, it wasn't properly fitted. If that doesn't work, then they've got different surgeries such as somnoplasties that will take care of any of the tissue in the way, because, well, chronic sleep deprivation is extraordinarily bad for your health. And it's not just chronic pain that is going to be on your ticket. You've got a lot of potential higher risks for not just heart disease, but heart attacks. Had a colleague that had chronic sleep insufficiency, where he was only able to sleep like 4 or 5 hours a night. This went on for a couple of years, and I think it was in his early 40s, he had a massive heart attack. So this is not something but to sleep on. We really need to take care of all of these factors and really get a full picture of our health, and doing everything we can to be better versions of ourselves, for ourselves and for our family, for our friends, for everybody. All right. Efficacy of manipulation and therapeutic exercise apply to the neck region of patients with temporomandibular disorders, a systematic review and meta-analysis. Long story short, any intervention on its own did not do super hot, but when you combine both, it seemed to do well because, like I've talked about in the past, you cannot treat TMJs if you also do not look at the neck. There's a lot of overlapping anatomy, a lot of overlapping neurology, and if you just leave part of the picture out, you're not going to stack the deck in your favor to really take care of these patients. So again, if I just jump to the conclusion here, manipulation of therapeutic exercise in the neck region can effectively improve the maxillofacial pain intensity and muscle related pain thresholds in patients with TMD. Manipulation alone has negligible effects on improving mouth opening, but the combination of manipulation and therapeutic exercise in the neck can effectively improve mouth opening in patients with myogenous TMD. However, many manipulative treatments and therapeutic exercises can be used for the treatment of TMD with varying effects, and more well-designed, large sample, randomly controlled trials are needed for further validation. That's true for most studies. You need further info. But again, it just highlights why we do what we do, and that's very rarely does an individual treatment in isolation actually have the compounding effects that we want when we're treating a very complicated issue, and TMJ is just that. It can wind up being a very complicated issue because of the unique anatomy and structures of the jaw, because of the very, very sensitive neurology would be putting it lightly. You got the trigeminal nerve, different branches of it going across the face in different patterns. You've got a lot of input from just behind the ear. So I know I'm talking ears here, but right at the opening of your ear, you can actually feel the backside of the TMJ joint or the TM joint. And just behind that opening of the ear, you also have a lot of overlapping larger nerve clusters coming from the actual spinal cord to sense the position of the upper head and neck. So it's a complicated area. And if you do not take a look at both the jaw and the neck when you're treating this jaw issue, TMD, you're missing a big chunk of the picture. So it's really, really cool that this systematic review, again, just highlights co-treatment of the area is effective for taking care of TMD. Does resistance training improve pain intensity, quality of life, and disability in people with chronic, non-specific low back pain? A systematic review, yeah. Resistance training programs effectively reduce pain intensity and disability in patients with that non-specific chronic low back pain. Moderate certainty of evidence suggests that it can be recommended for that condition, but further research is required to confirm these findings. What they really found was it showed significant improvements in pain intensity, quality of life, and disability, but only pain intensity reached clinical significance. So really the difference when we're talking about statistically significant and clinically significant is statistically significant means that there's enough to posit a potential effect and discussion for further funding for research. Clinical significance is something that you'll generally actually discuss with clinicians in the real world where, oh, hey, it's clinically significant, which means if you use this intervention, this treatment, this talking point, you will likely see benefit in the patient population at this approximate ratio rate or rate of improvement per person. So it's really broken up into two ways. So when you're reading these studies, don't get super excited if you see statistically significant or insignificant. It works both ways. You get a little bit more excited when we reach levels of clinical significance, because then you can actually start to expect to see something when that treatment is rendered across a population and not just extrapolated out from different equations within the study itself to be statistically significant. But that is a discussion that will confuse everybody, including me, if I keep going on for too long. So let's just move on to the next study. Factors related to the prognosis of chronic low back pain in older adults. Let me skim down here. Let's see. I kept this one because I just wanted to highlight the factors affecting the intractability of chronic low back pain were the intensity of pain, atrophy of the LM muscles, and let me just double because they like to say the same thing. That should be this is what happens when I go at rapid speed. I forget my abbreviations. Should be lumbar multifidus muscles. because that's usually what they study in these. Yep, right here, lumbar multifidus muscles. So what does intractability mean? It really means how well you can take care of the pain on your own. You have tractable and non-intractable pain, and they're really ones where either the pain can go away through different therapeutic interventions and allow for a level of self-efficacy. Basically, if I prescribe a patient exercises or lifestyle changes, mobility drills, maybe tweak the nutrition a bit, ask them to get some more sleep, a lot of those things that they can then do and take and maintain a level of autonomy should affect their pain. What happens is when we get into a level of intractability, is those avenues are no longer effective. You cannot effectively reduce that patient's pain outside of typically more drastic measures, if at all. So there are other conditions that lead to various levels of intractability, whether it is cancer and cancer treatments, neurodegenerative disorders and or syndromes, which can include fibromyalgia, chronic regional pain syndromes, things like that. Sometimes people with subsets of cluster headaches, the pain cannot be touched by almost anything, especially when it's active. So it's just a very nefarious type of pain that really cannot go away effectively on its own or with a self-management strategy on the patient's end. That's one way to think about it. If we wanted a Webster dictionary definition, I would have to, again, go back either 6-7 years when I was learning the term, or just go to Webster right now, which I don't have time to do because we got like another half a dozen studies. So let's jump to the next one. Exploring the role of, actually, let me touch back. So factors that will make the pain very difficult to manage on your own is if you do not maintain quality muscle tissue in the low back. So if we, again, go back to my whole resources analogy, if you take away resources available at hand in your low back to figure out where it's at in space, as well as manage exercises, load, etc., if you take that away from the body, it's going to say, well, fine, I don't have anything or anybody to actually work the job that needs working, so we're just going to be in pain. So you will develop a more nefarious and harder to manage back pain if you do not maintain quality lumbar multifidus muscles, and just stay as active as you possibly can, frankly. Now, moving on to the next study, exploring the role of diet quality and adiposity in the pain experience, mediation analysis. What was this? This was really just seeing, again, I'll jump to the conclusion. I've got too many studies to get through. On average, diet quality improved and pain lessened following a 3-month dietary intervention for weight loss. Changes in adiposity did not mediate this relationship. So it wasn't so much that the amount of fat tissue lost showed the relationship between pain. It was more the diet quality improvement overall, which will correlate, but not always, when it comes to adipose tissue loss or fat mass loss. So long story short, patients over 3 months during a dietary restriction, caloric restriction, improved their diet quality, and on top of them losing weight, they typically saw a reduction in pain overall. So to me, this is just, again, taking a look at person as a whole. Some studies we've been showing that BMI plays a role in chronic pain, and it's sometimes a discussion we have to have with patients when they're ready for it. If they want to pursue that aspect of their health, is finding different strategies that will make it effective for them to eat as quality a diet as they can for the lifestyle they have and the budget they have, etc. So it's important, folks. I don't just keep throwing in nutrition articles just for the fun of it. It's something that we do discuss and that we do help with if that's what you need. But yeah, not much more to say about that. That one's kind of self-explanatory after talking about some of the other factors for chronic pain and chronic low back pain. Next up, association between neck muscle size and physical features in individuals with chronic non-specific neck pain, a systematic review. I love the way that these Elsevier studies are made with the highlights, because when we're doing these fast reviews, we can just keep it simple here. Highlights. Smaller, deep neck muscles are linked to reduced neck endurance in chronic pain. And if we kind of go back to the intractable pain study, that typically will lead to less ability to manage your pain, and or you'll be more prone to developing it because your body doesn't have resources to handle whatever stressors thrown its way, and then it's more likely to pull the pain signal because it presumes it's in danger when it's really not. So smaller, deep neck muscles are linked to reduced neck endurance and chronic neck pain. Longus capitis, so a specific named muscle in the neck, size is linked to impaired proprioception in chronic neck pain. So the neck can't sense where it's at as well. So if it doesn't know what's going on, it's probably going to push on the brake pedal pretty fast. Ergo, it's going to produce pain when it doesn't have to because it's not sensing where the neck is very, very well. So it's just, if I can't sense where it is, we're not going to move. How do we make the neck not move? We give it some pain. Longus colli muscle size is related to increased postural sway, so the neck moving around more, and evidence for other muscle function relationships needs more research, like every other study that we covered. Conclusions based on very low certainty evidence, so basically proceed with caution as far as presuming this result. Reduced neck muscle size is associated with lower neck endurance, altered proprioception, and increased postural sway in individuals with chronic neck pain. So this is trying to give us a potential why, or posit a why behind why these people have or maintain a certain level of pain in the neck. Now, clinically, this is something where whether or not it is causal, I at least see the correlation where after improving somebody's neck endurance, then we get them to do different neck drills for neck strength, and actually incorporate it like you would with any sort of progressive overload program that you would for strength and resistance training. We do see very, very often, almost, I hesitate to say every time just because I am that kind of a guy, but almost all the time, if we do that for these chronic neck pain patients, we do see improvements in their overall function. This gives us a potential reason as to why, but like it said in the conclusion, proceed with caution because it's low certainty evidence. All right, we're in the back half, the back third, I think. 2, 3, 4, yeah, back half. Effects of different modes of exercise on sleep quality in adults with chronic low back pain, a randomized controlled trial. I'm not so concerned about the different modes of exercise. Suffice it to say, these highlights cover most of what I want to talk about. Exercise-based therapy improved sleep quality in adults with chronic low back pain. So all of these studies talking about modulating sleep and why it's good for chronic low back pain, about how it helps feed into and reduce your BMI. Now we're showing that exercise can improve sleep. Like we're hitting it from all different angles. Only general strength and conditioning improved daytime dysfunctions that they covered in the study. And only motor control and manual therapy improve sleep disturbance. So really they're subcategorizing why people have poor sleep, whether it was daytime somnolence, so you're tired during the day, you had more back pain, or if you had a proprioceptive issue, they subdivided it. Long story short, you don't need to go that far, because if you're doing a lot of the basic things that are talked about in every other bit of literature, you're probably going to be doing just fine to take as much improvement for your sleep quality as you possibly can. And it really only comes down to finding a quality practitioner to take care of the last part. So if you have some sort of a sleep disturbance, like there's an active pain syndrome that kind of gets you up in the middle of the night, that keeps you from getting a good quality of sleep, that's when you pull the trigger and see somebody like me to do these different things, these rehab interventions, these potential manual therapies that can have short-term benefits to start you down that process of getting a better night's sleep. And then the rest is up to you. Just do any sort of exercise therapy that includes resistance training and hits the guidelines that we've stated in several past iterations of this research review, and you should see an improvement in your sleep quality for a lot of multivariate reasons. We've got different potential things like improved tolerance and glucose control from bigger and more muscle fiber quality. So you can actually think of muscle as a glucose regulating tissue and on top of your pancreas. We can think of just the act of exertion. We can think of improved cardiovascular fitness. We can think of better perfusion of our body. reduced likelihood of developing pain. Like all of these things will play into why exercise will directly and indirectly help with your sleep. So if we're again talking about general health from all angles, got to get that exercise in. Next study, association between sleep duration and excess body weight of the American adult population. I think you know where this one's going. Conclusion, sleep duration is associated with the occurrence of overweight and obesity, with sleep duration less than 7 hours increase the overweight and obesity rate nearly twofolds comparing to sleeping 7 to 9 hours. So if you're not getting enough sleep, you're putting yourself at a higher risk for putting on extra weight. And I don't know how many people want that. If you do, get less sleep. If you don't, get enough sleep. That's pretty much all we need to say about this study. Next, non-invasive vagus nerve stimulation is associated with a reduction in persistent post-concussion symptoms in observational studies. So this one was just some people trying it out. They saw some results. They wanted to put it in the research just to say, hey, this is what we saw. So you researchers out here that actually have labs, that have grants, that have this might be something that you could pursue for further study. So what did they see? Let me double check here. I think this one's important where we should actually talk about some of the methods and results. So I'll go pretty fast through it. It was a single center observational study where they had 102 patients with mild traumatic brain injury who received an adjunctive vagus nerve stimulation as part of a standard of care. Symptom severity was measured using a behavioral symptom inventory at baseline and approximately 112 days post-treatment. The outcome that was measured was a change in that symptom questionnaire score, with secondary analyses explored associations between baseline symptom severity, treatment response, secondary clinical measures, etc. In the cohort, 16 of the 22 NSI symptom domains showed significant improvement after 3 months of treatment with that adjunctive vagus nerve stimulation. The most notable reductions were observed for post-traumatic headache, difficulty concentrating, dizziness, and depression and sadness. About 1/3 of patients met responder criteria for at least half of the assessed symptoms, indicating broad and clinically meaningful symptom relief. Length of the interval between injury and treatment initiation did not significantly influence baseline symptom severity or the magnitude of improvement. Well, that kind of actually surprises me. No adverse events were reported. And so their discussion is, in a more natural clinical setting, adjunctive vagus nerve stimulation was associated with significant reductions in post-concussive symptom severity across cognitive, affective, somatic, and vestibular domains in patients with mild traumatic brain injury. These findings currently support the use of vagus nerve stimulation as a practical, safe, and effective intervention for persisting symptoms due to mild traumatic brain injury. Further prospective controlled studies are warranted to validate these observations and elucidate underlying mechanisms. Wholeheartedly agree to that last sentence. I know it's a hot topic on social media, vagus nerve stimulation. There are legitimate benefits to quote unquote stimulating it. It is fascinating to think that for this complex condition, this could be something that can be utilized. I'm going to proceed with caution, though, until I see a more robust study saying that, just because I don't want to overpromise and overstep my bounds when working with this patient population, because it is such a multivariate, multi-symptom, complicated issue that people just see mild and then just assume, oh, it's going to be no big deal. Like, there are people that have been suffering for decades with very debilitating symptoms that are very pervasive and take away a lot of their quality of life. So for me, this is one where this study lets me, all right, I'm going to keep a weather eye on further studies that will validate that this is a legitimate thing, and or if there is a subset of MTBIs that would actually benefit from this versus just blanket coding it across an entire population if you have the diagnosis. So I know it's popular on social media. There are legitimate benefits for it for different conditions and subset populations, but like a lot of other things, it is not something that everybody needs all the time. And I do think it's one of those things that gets overhyped and that too many people are going to either blame it for a condition that they're just looking for a scapegoat, like, oh, I have X, Y, and Z, and it's because of my vagus nerve, so I'm blah, 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 blah. It's like I've had patients like that. or they're going to look at it as, well, if only I could stimulate it, then my condition would go away. Well, then we have that discussion of, well, what if it isn't? So there are purported benefits, there are studied benefits for certain conditions and populations to stimulate the vagus nerve. It's cool that this could be another, but don't buy into the hype on social media that this is a panacea, that the vagus nerve stimulation currently is a cure-all for a lot of the more difficult to pin down conditions that people will deal with. So just proceed with caution on this one. It's cool, it's prospective, we need more data, but we'll keep an eye on this one going into the future. Last two, we are almost home free. Association of cognitive impairment and spinal pain in the older adult population in the United States. Long story short on this one is, if you had significant cognitive impairment and you're older in this study, you were more likely to have spinal pain. And that can also be extrapolated as, if you're not able to comprehend or not get a quality education by a provider on the what, when, where, and whys of your pain, you're more likely to suffer more pain. A little bit paradoxical. It's one of those things where by ignoring it or not knowing about it, and it's really more than not knowing about it, you can make it worse because your body is allowed to, and your brain is allowed to catastrophize, which some people love the word, some people hate the word. It's really just a word of saying you're kind of spiraling down the, oh my gosh, there's a lot wrong with me, there's danger, it's something extremely bad, maybe it's cancer, maybe it's a tumor. Your body has a propensity to exaggerate what's going on if you're not educated about what is going on. And that was seen in the population when you had legitimate cognitive decline. So it's not like you could really effectively keep the education in this population. Like, take Alzheimer's, for example. If I'm not saying this is what they did in the study, I'm just saying, let's just segue into an example. If somebody with Alzheimer's, you educate them about the condition, Alzheimer's does Alzheimer's, they forget about it, and now you're kind of just left to deal with either going through the rigmarole over and over and over again, or this person's going to just circle the pain drain, so to speak. Anything else in the conclusion that they wrote that I want to cover? Significant association between cognitive impairment and spinal pain in the older population in the United States. Within this population, there were vulnerable subgroups for which spinal pain and cognitive impairment had a greater impact, namely people who are older, female, and those with less education. So no, just really kind of highlighted what I just said. Last one, the trigeminal cervical complex, a neural network affecting the head and neck. Let's see. I think this one was a hypothesis. Yeah, it's a hypothesis. So the conclusion for this one was that hypothesis. The authors currently wow, last study, can you tell? The authors currently hypothesize that the central and peripheral sensitization and the intricate connections to that trigeminal cervical complex can elucidate or give a reason why to the pathophysiology of conditions such as otalgia, tinnitus, hearing loss, vertigo, headache, cervicogenic dizziness, bruxism, and other symptoms affecting the head and neck. What the heck did I just say? Well, they are putting forth a theory, and they're trying to explain why people have these symptoms, whether it's in isolation or multiple amounts of these same symptoms in this area that overlaps with the TMJ and the cervical spine. I shouldn't say TMJ, the trigeminal nerve and the cervical spine. So they are positing as this trigeminal cervical complex. Put another way, if we go back several minutes in this video, I told you that it's a very complicated area. They're trying to simplify the education of that complexity by calling it a complex, making it easier for practitioners to talk about patients rather than saying all of these interwoven things like I'm trying to do. They're just saying, oh yeah, you're likely having these symptoms because of this complex, this TCC complex. We see that when there's issues with this complex, you can have, or it gives us reason to suspect that you'll develop vertigo, headache, cervicogenic dizziness, bruxism, because of the complicated, because of the complicated nature of the complex. Yeah, that's mainly it. It's really giving new terminology that's trying to aid in the communication of a complicated area. I think the only other thing would be, here we go, in the result. The review discusses the multiple afferent connections from the cranial nerves to that complex and their respective efferent pathways. These connections may explain the various clinical manifestations in the head and neck that cannot be attributed to other medical conditions. Additionally, the review highlights the dual sensory and motor nature of cranial nerves, emphasizing the bidirectional transmission of neurotransmitters in the head and neck areas, which leads to the sensitization of both the trigeminal cervical complex and the motor nuclei innervating the cervico-facial muscles, facial muscles. Fancy way of saying what I just said. It's a complicated area. They're giving you underlying potential mechanisms as to why, allowing us to communicate more effectively with the patient base about what is going on with all of these things and why they're both dizzy, why they can't hear so well, they have tinnitus, and now they're chomping at the bit quite literally with bruxism. So yeah, we're done, folks. That was a lot. I know it's still going to be a long video, even though we tried going quick, but thank you for sticking with me so far. And until next week, thanks for listening.